We're coming at you live from Cooper Hospital. So here we are.
So I think everybody knows why we're here today. And I'm Salina Wydo. I am strictly moderating. I have the distinct pleasure of getting to sit at a table with my partner, Dr. Nicole Fox, who's the current president of AAST. But she's so much more than that. And part of what we want to talk about today, or, covering the career catalyst is, you have a lot of different titles and you have a lot of different roles and you have a lot of different things with great value that you bring to the institution. So talking about the journey of identifying those strengths in yourself, how you advance along certain courses, really just finding out how you got to be who you are. So for those of you who don't know, Dr. Fox is here at Cooper. Cooper University Hospital is in
Camden.
I am already
Camden, New Jersey.
Camden, New Jersey. If you haven't visited,
it's a heck of a place.
It's a heck of a place.
Suggest a vacation.
Fly into Philadelphia.
Yep.
We're just across the bridge.
We're
We're level one trauma center, and Dr. Fox is the trauma medical director of our Peds Trauma Center. Dr. Fox is the associate chief medical officer of our entire hospital system. You have completed the course for the hospital physician executives. And you can speak more intelligently about that in a little bit rather than me butchering your actual titles. But throughout today, I'm going to be asking her a lot of questions about how she got to where she is, and we're going to kind of talk through it. But I also want to make sure that you all know the chat is open. And if anyone has any questions for Dr. Fox or anything you want to bring up, throw them on in there and we'll take some breaks and read those questions and give you guys the opportunity to have the field as well. That way it's a little bit more interactive than just.
Yeah, we want to talk to you and answer your questions, so absolutely feel free to use the chat. We'll try to, I'm not a technological wizard, as everyone knows, but we will try to find the questions in the chat and answer them.
Aaron may end up helping us out a little bit by reading them. So hang with us. We'll talk with Dr. Fox, and I appreciate spending your afternoon this hour with us. So I guess one of the things that I always had wondered, and granted, I have. Ever since I started, I have been here with you and I've watched your career and gotten to see you as I've grown up. So a lot of these questions are also things that I've wanted to ask Dr. Fox as I've looked up to her, and as I'm not part of the boardroom, things I want to know about how you get there and how you do. So before I even got here and met you, what was your very first administrative role, and how did you know that that was going to be something that you wanted to pursue?
So administrative role or leadership role?
Oh, I guess it's a really good differentiation.
Yeah.
Both.
Okay. So I think my first leadership role here by default was being the pediatric trauma director, which came a little bit earlier than anticipated and was by default, I think, vote. No one else wanted to do it. Let's be honest. Sometimes we get leadership roles that way. But I was really passionate about us becoming a verified pediatric trauma center. And I can be like a dog with a bone if I feel strongly about something. And so I really proposed this idea, and we needed a pediatric trauma director. And so I was asked to do that. I don't think I really realized I was stepping into a leadership role, but I was. It was about 3 years into my career here, so a little earlier than anticipated. But that was really the start, kind of the catalyst of my entry into hospital leadership.
Had you known even prior to that, though, this was going to be something that you were interested in, that's something that you wanted to be part of your practice or part of your career path forward?
Well, I could say no. I think like 10 years ago, I would have said no. But then when I think back, and I think if you talk to a lot of people about their journey, you start to see patterns that do emerge earlier than you realize they were emerging. So what happened to me was that I didn't get into medical school right out of college. I took gap years at the time, which are fashionable now, but at my level, you just couldn't get into med school, so it wasn't fashionable back in the day. And one of the things I did was I waitressed at Houlihan's, full disclosure, and someone there, one of my customers, offered me a job. This sounds like the story's going down a bad road, but it's actually a good story. And they offered me a job. This guy turned out to be a multimillionaire. He was a CEO of a health insurance brokerage firm. And it was a firm that sold health insurance to different places. If Cooper Hospital wanted health insurance for their employees, or Burger King wanted health insurance for their employees, this firm would help shop for them, craft the plans, and they would serve as the broker between the customer and the health insurance company. And that opened like this whole world of managed care to me and sort of the business aspect of medicine. He knew I was going to medical school, so my employment was going to be short-lived. But before I went to med school, he said, look, you can go, but you really need to promise me that you're not going to be one of those physicians that puts your head in the sand and knows nothing about the business of medicine. You have to figure that piece out. You have to be informed. So, I thought, okay. And I asked med schools, like, how could I get that education? And none of them really had an answer. But where I ended up going to med school, they said, look, you could do your master's in public health. We're looking for people to do the program. You could do your concentration in health administration, take classes at the Rutgers at the business school, and maybe that would give you what you need. And they were willing to pay for it. They were looking for students to do it. So I said yes. And I think that was really it. Now we're going back 20 something years. So I think the seeds were planted then in those classrooms at night after med school was over. I would go to school at night at the business school, and I would sit with people who worked in real jobs all day and learn about budgeting and leadership and negotiation and things like that. And I think I was forming the early basis for my interest. So it did start a little earlier than probably I would give it credit for. And then I was really lucky to do residency at Christiana in Delaware, and Mike Rhodes was the chair. Mike's one of the founding members of AAST, Dr. Rhodes, and he saw this interest in too, and he had a very similar interest. And so he really encouraged that during residency, promoted it, would get me involved in projects that were a little out of the clinical realm and more operational. And so the ball sort of just kept rolling from there. So it definitely started pretty early.
So you mentioned something earlier that I thought was really interesting. I asked about the administrative role and you said administrative leadership. How do you see those two things? Because I think too frequently, and as I just did, we conflate those two with being sort of the same thing, that administration is leadership and that leadership is administration.
Right.
Where do you see the difference being? And then what was your first administrative role?
Yeah, well, I think why I distinguished was because there's clinical leadership, and that's sort of the path that all of us in academic surgery or whatever, get put on if we want to go in that direction. And that, to me, that means, a division head, department chair, dean of a medical school, sort of that tract. I separate that out from other leadership roles in the health system, administrative level roles. So that when I think of that, I think of the C-suite, I think of vice presidents, executive vice presidents, CFOs, CEOs. And they're two kind of distinct paths. I think what I'm doing is living on both paths and trying to merge those two, being a clinical leader and an administrative leader.
It seems like they take different skill sets, complementary in ways, but different.
Not even complementary, sometimes 180 degrees opposite, right? So we could get into that. But my first administrative role here was, again, by default, sort of like the pediatric trauma thing. But I had reached a point of absolute burnout as a trauma surgeon very, very early in my career here, where I really hit a wall physically, mentally, emotionally with the work, because the work was just unsustainable the way we were doing it here at the time. And I think some god of somewhere, saw that happening. And I was asked to look at a job. And when I got the job description via email, I almost vomited, because the job was to be the medical director of clinical documentation integrity. And I literally didn't understand a word of the job description, not one word. It was like DRG, CMI, bip bop.
Those are all words and letters. I just don't know what they mean put together.
No clue. And I almost thought it was like a joke. Also at the time, Cooper's worst documenter, I had 1,100 unsigned charts in my Epic inbox. And these people were asking me to run this program. And I got the job. And that opened a Pandora's box to the other side of healthcare, really, kind of got a foot in the door in terms of administrative leadership. And I loved it. Despite myself, loved every minute of it.
Well, what did you love about it?
Oh, God. Everything. First of all, I met a whole different, it was like falling down a rabbit hole into Wonderland, and you land at that table with all the Mad Hatter and like all these strange characters who are speaking in like languages you don't understand. But I started to really understand what was going on in the system because I was sitting at tables with people from finance, people from compliance, people from quality, people from all these facets of the healthcare ecosystem that I had no exposure to. I was like purely a trauma surgeon. That's what I wanted to be with my whole life. And now all of a sudden I was having conversations with these people and really starting to understand why things happen the way they do in the system and what goes on behind closed doors. And they all seem to be really cool people. And they put a lot of color into my world. And were really informing me in my day-to-day work as a trauma surgeon. And it became so addictive, just this flip-flopping back and forth and getting to hear like the whole picture. and not being in that us versus them mentality, that I just loved it. I love learning a new thing. I love learning about hospital finances, revenue cycle, compliance. I really enjoyed it. It like filled a void in me, I guess.
Where did you go from there?
Well, there I went to the associate chief medical officer at the time left our organization to go into private industry or something like that. And the next thing I knew, they were asking me to do that role, which again, that's like reading the job description for something you don't even know what it means. So I just said yes, which has been the story of my whole life, just saying yes. And that was kind of the next step from there, which was a big leap from medical director of clinical documentation integrity to associate CMO, but that's how it went.
It sounds like it brought a lot of new challenges, and actually, rather than taking somebody who's burnt out and giving them more work or different work and adding to the pile, it actually refreshed sort of what you were doing. Is that
well? Yeah, it's funny you say that, because what happened was when the person who asked me to look at the job, it was the CMO at the time, who's now our co-CEO, but he was the CMO at the time. He asked me, I was getting coffee in the coffee shop, and he told me he was going to email me this job description. And I was so burnt out at the time. I just said, oh yeah, sure, I'll look at it. And he said, look, it would be 30% of your time. It would be less trauma call and less clinical work. And when I got the job description and I almost vomited looking at it, I just kept hearing that voice in my head, like it's less trauma call and less clinical work. And I thought to myself, if I feel this demoralized at this point, if he's asking me to take out the trash as a job, maybe I should just consider it, because maybe it'll give me some breathing room. Maybe I can take a step back. Maybe I can reset myself, because I can't quit. I worked my whole life to be a trauma surgeon, and feeling like that was crushing me. The fact that I hated it was crushing me. And so I thought, let me just I'd give anything a try at this point. And so it did refresh me. It kind of hit a reset button. And I tell him to this day, like, you don't realize what a hand that was that reached out and grabbed me. I know you were just looking to fill a position, but it actually was like a career saving move. And so I'm very grateful for that.
So you just said a couple of things that I thought were really interesting. One of the questions I wanted to ask later, and I'll come back to, is you're mentioning how important being a trauma surgeon is to your identity, and talking about all of these different identities that you've sort of come through in your career. So I do want to bother you about that a little bit more towards the end.
Mm-hmm.
But one of the other things is falling into these positions and then having an entirely new perspective and getting to bring that. One of the things that I know you do that we haven't mentioned yet is you have really been a huge champion of the peer support program. You were the one who started the peer support program here. Is the things that you went through kind of what informed your desire to work with physicians who were like burnout, in trouble, having crisis?
That's a good.
Let's tell them about the peer support program.
Here we go. Well, what happened was, and we'll take a question from the chat soon to break it up, because I feel bad for all of you just having to look at us. But no, what really informed the peer support program was this. In the associate CMO role, I was tasked with, for whatever reason they would trust me with this, I don't know, but handling physician issues that rose to the level of the CMO office. So physicians who were struggling in the health system for whatever reason, they were cursing in the operating room, throwing instruments, not showing up to work, sexual harassment, racism in the workplace, all these kind of issues. Once that had escalated past their division head or department chair, it usually goes to the CMO office. And they were giving me these issues to tackle. And I was really puzzled, like, why would a physician who worked their butt off, to go through medical school residency, they're in a high functioning role, why would they compromise their entire career by doing something like throwing instruments in the operating room or touching someone inappropriately? Like, I couldn't wrap my head around that. And I thought to myself, well, maybe I should just ask them why they're doing it. So every time I would sit down with one of these physicians, I would start out by saying, like, hey, you're a really accomplished physician, even if they weren't, I would just say it, to be honest. But I'd be like, you're a really accomplished physician. We really value your contributions to the healthcare system. Why are you doing this? Why on earth would you, I know you don't want to be sitting here with me. So what's happening? Like, what's going on that you would be acting this way? And then I would just sit there and I would wait. And like 99 times out of 100, something would come out of their mouth that would break your heart. It would be like, my son died by suicide 6 months ago and I shouldn't be here. Or my wife just left 2 weeks ago and took the kids and I haven't told anybody. Or I have metastatic cancer and I shouldn't be working. And it was like over and over and over again. And I was like, I would say to them, all right, now we can get somewhere, because like your behavior has to stop immediately, where we have to fix that. But like this other thing is huge that you just told me, and we have to help you with that too. Like, and so peer support emerged out of sort of a need that I saw to kind of create a better culture. People shouldn't get to the point where they can't ask for help. They shouldn't get to the point where they have metastatic cancer and no one knows and they're trying to work full time. And if we're encouraging that type of environment, we really have to change course pretty quickly. I also saw myself in a lot of them. I went through a terrible divorce. You know, I have a lot of kids, as you know, that are hard to manage at times. I have been burnt out in my career, like I just said. So I would see myself in them and I would identify immediately. And just like our CEO reached out and helped me, maybe unknowingly, I just made it my goal to try to create a culture here where people felt safe and where we could help them and hopefully salvage their career and not watch them derail it.
I don't think that that's where Dr. Fox thought I was going to take this today, and I actually hadn't really thought about that or prepped that. But one of the things that I think is really important that you brought back to our group from the boardroom, and we'll take a look at the chat, see if anybody's got any questions. But from my observations, one of the things that I think that you brought back a tremendous amount of value from the C-suite is all of those leadership skills and how you manage and how you help manage and guide a lot of us in this division, either as an official mentor or just as someone who has a lot of experience that we go to and we turn to look for help. You've worked through so many difficult problems with other people that you know how to resource that and to help, guide. So let's look at the chat. Sorry, I'm gonna get real close.
No questions in the chat, people, but
Nobody yet?
you can put them in or somebody can talk, because
Yeah, put a hand
we'll
up.
just go on all day. Her and I could. Yeah,
Full
give
list.
a list of questions. Anything right now before we move to the next topic? Oh, yep, I see a hand raise. I love this.
All right, let's go.
This is so
Hey,
fun.
Nicole. Hey, it says Catherine, but it's Lindsay McKnight. Nice to see you again. When you stepped into that leadership role where it decreased your clinical load, and you decreased your call, did you have any conflict with any of your partners when you decreased your call?
You must be a plant. You must be a plant in the audience.
I didn't prep her.
Were you on faculty at the time that happened or no? I don't think you were yet.
What?
When I took the clinical documentation thing.
No, you had already been in that when I came.
Okay. So yeah, it's a great question. I at the time, and I want to just make sure Salina wasn't in the group. At the time, this was a very old school, male dominated group of trauma surgeons who were all older than me. I was certainly the most junior faculty in the group. This did not go over well. And I said to my CMO at the time, hey, who's going to talk to my group about the fact that I'm going to be taking less call, taking less clinical work? He was like, you are. I said, what? I said, that's not going to go over well. He's like, no, I'll just tell you one thing. Pigs get fat, hogs get slaughtered. Be a pig, don't be a hog. I was like, what in God's name does that mean? So I went back and I realized what it meant, which was, first of all, I didn't reduce my time right away like that. I knew I was going to back into the role, but I started having these discussions about, it occurred to me in a moment of brilliance, which I rarely have, but this was one moment in time of my whole life. I realized that if the hospital was now going to pay 30% of my salary, that the surgery department would now have 30% more money. And where was that going to go? That should be distributed, in my mind, to my partners who are now going to take more call. I thought this was a brilliant idea. It's genius. So I put it forward to the chairman of surgery, who promptly shot it down at the time and said I was absolutely crazy and there was no way that money was going to my partners. And I thought about that, and I did end up going back to the CMO and telling him like that I had come up with this idea. He's like, that's brilliant. I'm like, well, the chair of surgery didn't like that idea. He's like, well, and so a lot of discussions were had, and it was ultimately decided that money would be distributed to my partners. I paid a price for that because it really ruined my relationship to a degree with my chair of surgery. So I closed a door that never really reopened, but my partners were happy. And that's what mattered to me the most. Because I'm working with those people all the time and they need to be treated fairly. So I took the hit there a little bit. It never recovered. I never recovered that relationship to the degree that I would want to, but it worked for everybody. And it was the right thing to do. I think if you're really focused on what's right and what's equitable for people, you gotta take the hit sometimes, and that was a hit, worth taking. But yeah, the initial conversation, I think for everybody that's listening and who's facing this situation, you can't go in there like gangbusters and think everybody's gonna be thrilled for you and just take up your call. There has to be, you have to make that whole somehow. And so that was how I did that.
That's actually an awesome segue to like one of the next questions I was gonna ask. Lindsay, you are a plant, I swear. I didn't prep her ahead of time.
That's great.
No, but one of the things that it comes down to a lot seems to be money. Not just for us as individuals, but really for the institution and into what buckets things go and people's line item budgets, et cetera. So how do you, when you're going from a role that has very clear value, FTE, like we know exactly what an FTE is and what it should be like, and you know what it should be worth. How do you start to justify the value of your work when it's not clinical?
Yeah, this is a great question. And this is where you have to get really creative, because we all know how to value clinical work, whether it's RVUs or, you know, we all know that money in equals money out. Yeah. Well, no, FTE time. When you're in a non-clinical space, you do have to really think about the kind of work you're doing and then what outcomes are associated with it and then what value it may bring, right? So, and you may have to ask for help with this. And I do that. I still do this all the time. For example, I've been trying recently to value the work that I do with the physicians in the organization, right? So if I'm working with all these physicians and I'm spending all this time and helping them navigate their careers and salvaging some of the careers, getting rid of some of the ones that maybe shouldn't be in the organization, how is that valuable to the health system? So one of the metrics I use for that is retention, the ability to, so I did an experiment where I looked at all the physicians that had left the organization in the past 5 years. I asked HR, what does that cost? I asked my human resources partners, what does it cost when a physician leaves the organization? Well, they told me it's 1.5 to 2 times their salary. So every time we lose a physician, we pay that money to recruit a new one and bring one in. So I just started using those numbers, like, hey, look, this year, or this is what it's cost us to lose all those physicians. And then I went through my spreadsheet of physicians that stayed after we intervened, and I kind of equated those numbers. It's sort of fuzzy math sometimes with these things, but it's as accurate as you can get. And I've had to really rely on asking people outside of my wheelhouse for help with this. I asked the finance people, like, why do you think this is valuable to the organization? Say it's the clinical documentation work. How is this valuable? Well, this is there's X amount of revenue recovery associated with the physicians answering these queries. You can equate value to the things you do, but it takes a lot of creativity. And you have to think outside of the box when you do it, but it's a really important question.
So one of the things that you had mentioned earlier that I've also been thinking about, so talking about justifying value, what about advanced degrees? What about folks who think they may want to pursue one to help with some of their clinical or administrative aspirations? Is it necessary? How helpful do you think advanced degrees are?
I think it's really an individualized decision. And I think that, again, it has to come from a place of, is this really something that's of value to you? Do you want to do it? Are you interested in the material? Financially, is it feasible? And do you have the time? If the answer to all those questions is yes, then I always encourage people to pursue an advanced degree. But it's not necessary. I don't think it's necessary for advancement. I know that when we're interviewing for executive level roles here, that's not even on the list as far as consideration. I think also you want to think about the fact that sometimes if you go to get something like an MBA, there's a lot of content. Some of it may be what you need to advance your skill set, but a lot of it might be lost on you. So you can always think there's a middle ground. There's a lot of programs that aren't full degree programs that can give you what you need, like skill sets, in a shorter amount of time for less money. And there's a lot of organizations that promote programs like that, like the American Association for Physician Leadership, AAPL. I'm doing a program now through Drexel called ELAM, Executive Leadership in Academic Medicine, which is, a short course. It's like a year-long course, but focuses on a lot of things like finance, how to market yourself, how to work with boards, like skills that I really need. Without all the other noise that might come with getting an MBA or an MPH or an MMM or MB. Well, they have like 50 million degrees. But if you're interested and you think it's something that you really want to do, go do it. I mean, I think it's worth it. But
And I take it the same thing comes with, if you're trying to get your institution to pay for your degree, you better have some sort of idea of how this brings value, how to quantify said value, how to come up with a proposal that makes sense and speaks in a language that they'll understand and value, I guess.
what's the return on investment for them? Yeah, what's it gonna do? What is them subsidizing your degree gonna do for them? Sometimes it means signing a longer contract. They want to know that you'll stay there and use the skills there. Sometimes it just requires like being creative and thinking about what you could do with that degree that matches with your health system's goals and objectives over time.
What do you think the hardest decision that you've had to make in your leadership role? What do you think that's the hardest professional decision you've had to make?
Oh, I think, it's a great question. I think every time I move further away from clinical work, it's like a knife in my, like it's physically painful to do it. And I think that those are the hardest decisions that I've had to make, is how much time to commit where and when to put my energy in what place. That's been really hard. This job is all most of you are probably trauma surgeons on the call, maybe not everybody, but this is a no joke job. To me, like, trauma surgeons are the most agile members of the healthcare. There's no surgeon that does what we do. And I take a lot of pride in that, like having that ability to do it. And to walk away from that even a little bit, some of it's a relief, like not taking 24-hour call. Spoiler alert, that is a total game changer. Okay, it's a relief. But not being part of the mix, not being in the arena all the time, it's physically painful too. So that has been the ongoing hardest decision of my life. Like every time I have to ease away a little more, it gets tougher and tougher.
I think the title is To the Boardroom and Back. And I've also noticed over the past couple of years, I've seen, and we've had conversations and I've seen that struggle, and I've seen you actually come back into the clinical world a little bit more and it's really cool to see how much, to see when we're on service together, and I'm like, she loves this. But what is it that pulls you, what is it that keeps pulling you back?
Well, I'll tell you something, and hopefully, Erin, I don't know who's allowed to listen to this, but maybe not my administrative colleagues, because I'm gonna spill a little secret here. The non-clinical jobs can be very vulnerable. Those jobs can come and go, right? Those jobs are not guaranteed. So, we're facing some tough headwinds in healthcare in the next few years with a lot of what's going on in the world. They could say tomorrow, we don't need an associate CMO. Why do we even bother? We don't need a chief physician executive. We don't need a CMO. I don't know, I'm making it up. We don't need a vice president of strategic planning. Those roles can really come and go, and I'm hyper aware of that. The bankable skill set that I have is being a trauma surgeon. The thing that's going to pay the bills, subsidize my living, my family, is being a trauma surgeon. So I always encourage people, don't be so quick to give up this skill set, for two reasons. One, because it's what's going to keep the lights on at home. But two, because you worked really hard for this. Like this was a lot of hard work. So to just abandon it completely, that's a big sacrifice. And I think a lot of people would regret doing that. And if you have the opportunity to move back and forth, like I do, take it, take it and run with it, because it is really a unique opportunity, and you can, sort of serve both purposes and really have a fulfilling career if you have the opportunity to do that. I think a lot of people believe it's all or nothing. You either have to be here.
We are very, and that's our personality.
That's very trauma surgeon-esque, right? It's live or die, it's CAT scan or OR, it's very binary. I'm trying to show people that it doesn't have to be binary. It can be, I used to say I'm trying to walk two roads. I think I'm really just trying to merge the roads. I think I'm trying to merge the roads and show people that there's no reason that you can't do both. I don't know if it's working. A lot of silence and nothing in the chat. So
I did see a hand raised.
Oh my.
Whoever, I wasn't able to see who it was. Do you want to unmute yourself?
Can you hear me?
Yeah.
It's just, I'm really enjoying the discussion. You were just briefly touching on something where my thoughts were going about sort of changing headwinds and kind of the political state of our country, the value of what physicians do. I feel like I've seen in the past 10, 15 years, a continuation of a trend that I think has been going on long before me, which is really, I think, valuing the physician's work less and less. And I've been in leadership roles and kind of got burned out in that as well, just feeling like you can't make any progress because there's such a focus on profitability. I know this is a trauma group. I'm trauma and acute care, and I've worked in elective realm as well. But I just didn't know if you could speak to that, being on the administrative side and your experience and kind of, working with the C-suite and trying to get them to understand really the value of what we bring to the table.
Well, I have to tell you, it may be an unpopular opinion. I think we are our own worst enemies in this fight. Because as you said, I have the perspective of working in the C-suite. So I watch physicians of all specialties negotiate for themselves. The worst negotiators are the trauma surgeons. They are the absolute worst. And it's the C-suite knows it. They're very aware of it. And they bank on that. They bank on having people who will do a tremendous amount of work and not ask for much. And let's take it a step further. People who do a tremendous amount of work, not ask for much, but when they ask for something and are told no, they just walk away and don't ask again. That's we take our altruism a little too far, and it becomes pathologic for our profession. So I think we really have to work on advocating for ourselves as a profession. There is a tremendous financial value in what we do across the board. And some centers more than others and some centers less than others. But the umbrella of services we provide that most of us are doing now, acute care surgery, surgical critical care, and trauma surgery, that's incredibly valuable to any organization. Any of those standalone, sometimes trauma is not the money maker, but critical care definitely, is a very lucrative thing. And acute care surgery, believe it or not, and there's a lot of literature on this. People who have written about the value of acute care surgery, the economics of it. And so we have to really familiarize ourselves with that data and negotiate a little better for ourselves and advocate for ourselves. I think we're doing ourselves a disservice with this. And I've watched it because if you watch a CT surgeon negotiate for themselves, it's 180 degrees different than what the trauma surgeons do, or even the oncologist. When they know they have
Ortho.
and they fight for it, they'll get what they need, because the C-suite, the people on the other side, they're good people. They are looking at a huge system that has many, many needs and a tremendous number of people at the table. So we're just one person at a very huge table. And you really have to keep hammering the point home and negotiating and renegotiating and asking again, because you're drowned out sometimes by all the things that are going on in the system. But they do know that the value's there. I think we have to be better about illustrating that and bringing it to their attention. So I kind of blame us for that. Might be an unpopular opinion, but I do think there's a lot of work to do on our end. And people like Pat Murphy and Jamie Coleman and Mark DeMoya, they're doing the work for us. They're publishing the data, they're bringing it forward. We know what the problems are, and now it's time to to act on it institutionally in our own organizations. Use that data, take it to the table.
I think that's a good segue, because we actually have another question. We have a question in the chat.
We can't read, we
And
can
it's
read
not-
it,
I know.
so we're gonna lean forward.
I turned 40 and I stopped being able to see.
So do we go one by 1, 2, 3?
Top to bottom is the numeric order in which they came in. The top one is, I think, also relates a lot to what you were just saying and some of the work that's kind of being done for us about the full FTE time periods.
Let me do number 2 first. The hospital did offer the 30% salary compensation. So
the question was, did hospital offer 30% salary compensation, which is more realistic FTE buy down of our time versus stipend / flat hourly rate, or was that something you specifically had to negotiate?
Yeah, so the individual, David or Drea, I'm sorry, is asking, like, how did that 30% come about with my clinical documentation role? And that was offered, that was suggested by the consulting firm who suggested that they hire a medical director for the role. So they came up with the 30% and the hospital went with it. You'll find that most health systems have a pretty set value for different roles, what they're willing to cover. So at Cooper, for example, medical director roles usually it's 10% FTE, which is low, I know, but I'm just giving an example. Some other roles are 0.25 FTE, but health systems have some kind of fixed ideas of what they want to compensate various roles for, and they usually stick to it. You can try to negotiate a little wiggle room in there, or as your responsibilities grow, try to increase that FTE allocation. But they're pretty savvy with that, and they do it on the executive side as well. So they have a pretty deep understanding of how to allocate that appropriately so it meets the budget.
Yeah, I think we're this is Drea Long from Fresno. I asked the question. I think we're a little bit of the a number of years of doing a lot for not for much. So we've kind of backed ourselves in a hole where we get stipends. We don't get true FTE compensation from the hospital, and like how to negotiate that now when we've been doing it for our entire program here has been quite the battle. But that's why I wondered, was it just kind of like an easier thing? And it sounds like it was pretty well. They respected the work as a surgeon, which is different than, the work of someone different doing that role.
Well, that's a good point, right, that you're bringing up, because you do have to ask that. One of the things they mentioned to me, and I didn't even think of it, and I didn't even think it was an issue. I took this for granted. They said we were willing to pay you at the surgeon specific rate of 30%. I'm like, what does that mean? And they said, well, if we hired a hospitalist for this job, it'd be cheaper for us because they don't make as much as you do. I'm like, whoa, what? So that was a little lesson, like an inadvertent lesson. I didn't even know to ask that question, but they mentioned it. And then as I've increased my administrative time over time, I've had to fight again to be like, I still want the trauma surgeon rate. And, they pushed back sometimes and said to me, there's a limit to how much administrative time we'll give you at this salary level. Because, and that's why I think personally, that's why you don't see a lot of neurosurgeons or like real high earners in these kind of roles, because for many of them, it would mean a pay cut if they're not willing to pay them at the surgeon specific rate or the specialty, I would call specialty specific rate. And that was an inadvertent lesson, like I said, but that's really important that you're bringing up. There was a question at the top by Dylan. I didn't want to lose track of it. They're asking, I spent a lot of time trying to find balance, not so successfully. How do you think moving into non-clinical roles affected your balance? I think it's a mixed bag. I think it affected it negatively and positively. Some people would be like, well, she doesn't do as much trauma. She must have much more balanced life. I can tell you one of the things about hospital administration is it's a 24/7 operation. Okay. And so they expect 24/7 response level. And that has been tough to set some boundaries around that because the phone can go off at 10 or 11 o'clock at night for, we know what an emergency is in our world, right? Life or death. It's a different level of emergency on the other side. And so I have had to grapple with that a little bit because it can just go on all day and night. Even tonight, I'm going to school at 9 o'clock, like at 8 o'clock to 9:30 or whatever. So, but in a lot of ways, it's also afforded me some flexibility and the ability to control my schedule. And so I would say overall, it's been a win. But, it is a constant struggle to maintain balance with the two roles. So it's not as glorious as you would think, getting a buy down and then moving into administrative role. There are definitely some. Sometimes it would be easier for me to be on call, honestly. I would be like, I just want to be on call so everybody leaves me alone, and I can just take care of patients and not have to get all the phone calls and stuff.
And there's a certain amount of, though our job is extremely unpredictable, there's a certain amount of predictability to ours.
Yeah.
Whereas some of the things that I've heard you say is some of the calls that you'll take, there's some of the issues that they expect you to handle are unpredictable, somewhat strange, unconventional. And granted, again, we are people of an unconventional skill set, but it seems like that's actually the less predictable of the two roles.
In a way.
Despite being called for a GSW at 2 a.m.
In a way. Yeah, that's very true.
There's another one. This is, can you comment on the path or transition to leadership roles in surgical societies? I'm guessing AAST or AAST. Is it hard to balance all the responsibilities and all of the requirements on top of what you're already doing? Yeah, well, yes.
Yes, it is. But
we love you, AAST.
It's so worth it. I have to tell you, I was on a panel of women physicians, not all surgeons, but somebody brought up the importance of volunteerism with your national societies. I have to tell you, of any sacrifice you make with your time, I think that is so worth it, being involved in your national organization at whatever level, because you get to meet so many people, you get to hear so many perspectives, it pays dividends for that, the amount of volunteerism it is. What East has given me, I could never repay. I mean, just in terms of the friendships I've developed, the education I've gotten, the opportunities, it's insane. So I think volunteerism nationally for whatever organization you like should be East Limited. No, I'm just kidding. But AAST, Western Trauma, all the great organizations, Pediatric Trauma Society, it's worth it. It is just, that's all I can say about it. It's worth it. It's tough. I'm not gonna lie. It's a lot of work. But you know what you're getting into, and you have to decide, is this realistic for you timing wise? You know, are you at a point in your life where you can accept that amount of responsibility, or should you do it at a lower level? But I think this is something that most physicians, not just surgeons, would say is worth it. This is the type of volunteerism that pays dividends.
The amount of friendships you can make, and not even, I mean, some of it's the friendship, but some of it's also the professional relationships, the different people, the different aspects people can mentor you in. Very rarely do you find somebody at your own institution or in your own local circle who can be a mentor in both research and leadership and education and being able to be in such a large group of people sharing their talents and interests is pretty cool.
And Drea, to your point, it's like, you can ask some of your friends, as you meet more people through your organization. I'll ask people, hey, what do you guys pay medical directors, or how much time allotment does your trauma medical director get? And you can get perspective from so many different areas, and then bring that back to your institution. Because knowledge is power. So.
Yeah, I think that's good. I think sometimes the specifics of money, it really depends on people and what they're willing to share. But I don't know. I fully believe in transparency. I share everything with all of our new colleagues and stuff like that, because it definitely makes a difference. But I think that also limits sometimes getting the best compensation from the hospital. It's like I can't even get, what across the city, at a different rate. But I think the more that we talk about it, I agree. The more that people actually are willing to share. Yeah.
So we know that your first sort of role was that of the trauma surgeon, and you've put on the different hats, that of the boardroom, that of, national organization leadership. How do you think your transition to the boardroom changed you as a person, and your time as East president and on the board has changed you as a person?
Yeah. Well, fundamentally changed me as a person. I think the thing you figure out and maybe it's the same, I don't want to just talk about the boardroom, but this is the world I know. I think when you make a transition into a totally different world like that, a mirror comes up to you about some of the things that in your personality that may be holding you back, that are very difficult. It kind of holds a mirror up to who you really are, and you have to face some tough realities about yourself. For trauma surgeons, the tough reality that I've had to face is those skills that make me really successful as a trauma surgeon, the aggression, the decisiveness, making quick decisions with little information, they will completely backfire in the administrative world. So I really had to kind of learn to be a different person, more patient, more empathetic, listen. I had to learn to listen to people, which is nearly impossible for trauma surgeons sometimes to do. I had to learn to be a beginner again. It's really hard when you're at the top of your career clinically. You feel like you're at the top of your game, you're a full professor, you're doing this, you're doing that, you're leading your national organization, but you're still treated like a beginner in some aspects in your other role. And that's hard to reconcile. And you have to really learn to put on a game face and accept feedback. And you think you would be able to do it really easily, because in surgery, we give each other tough feedback all the time, but it's almost in a more direct way. It's easier to accept. Over there, it comes at you a little bit differently, and it can be really painful. It can be very cutting. And you have to learn to either accept the feedback and work on your weaknesses and build to your strengths, or you're not going to survive over there, because there's 100 other people who could do your job, and they will. So you have to be really honest with yourself and be able to be introspective. So I've learned to be more introspective.
What's the toughest feedback you've ever received?
God,
We're still gonna be friends after this, I think.
Yeah, no, I mean, I've had people tell me, I don't think you're a good leader. You know, I don't think you're leading well. I think you came across as X, Y, or Z in that meeting, or, I don't think you know enough about X, Y, or Z, you know, just really pointing out like blind spots in my knowledge base, which is really hard. You know what I mean? It'd be like you being in the OR and the fellow saying to you, I don't think you know how to take out a spleen. You'd be like, oh, you know, nobody's ever said that to me. I am legit. I can take out a spleen, but I think,
They've not said it to me either.
in the other world, people have said to me, I think you're really weak in finances, or I think you're really weak with your revenue cycle knowledge and you need to ramp it up or you're not going to progress on this track. And it's like, oh my God, you know, I feel like I've come so far already and now you're telling me I have even farther to go. That feedback's really difficult for me because it means like I just need to keep trying, improving, going back to the table, and you already feel like you've made it so far. So that's tough. And to hear things about your personality that you don't like. Oh, and the other thing I'll say about being a leader in general, accepting the fact that not everybody's going to like you. I'm a pleaser by nature, believe it or not. I know I have a very strong personality, but a tendency to want to please and make everybody feel included and good. And there's times when you're making tough decisions that people are really not going to like you. And that's hard. So that's like unsolicited feedback, but you know that they feel that way, and that's really hard.
I saw a hand raised.
Oh yeah.
Whoever that was, unmute yourself.
Keep it
Come on,
coming.
it's your turn.
Yeah.
Me.
Oh, Miriam. Miriam's our fellow. Oh, that's a
Cole.
oh. No.
Hi. So, my question is, as a fellow, someone who's kind of right in the beginning of their career and trying to figure out like what kind of structure I want to have with my career. I know you had mentioned before, like getting advanced degrees and stuff. Let's say maybe that wasn't part of the picture. How would you suggest to like get involved in kind of hospital administration to kind of dip my feet in a little bit to try and see what kind of roles I may be interested in? Yeah, that kind
In
of thing.
fellowship? Or
Yeah, just to start in fellowship, maybe just to get an idea for it and then to go forward. I mean, if I know it has a lot to do with like who you know and the connections that you make, and that's important too, but like, you know, are there any like specific like meetings to go and sit in on and to like
experiences to help figure out if this is going to be
yeah,
you're interested and want to keep
right, exactly.
developing.
yeah.
Yeah.
That's a good question. I would say during your fellowship, and I'm going to say for the first 5 years out, I'm going to give this window, the absolute focus has to be becoming a clinically excellent trauma surgeon and surgical intensivist. So the focus can never waver from that. But you can find ways at the fellow level. I would just start talking to a lot of people. I would go to a national meeting. I would start talking to people with varied experiences. If you think you're interested in something like hospital administration, go to a session on that at a meeting, or like something where they're talking about trauma finances or operations, and see if the information even appeals to you. Like you're in what I would call the exploratory phase, right?
Yeah.
Someone's going to give you a leadership role. So it's like, can you get on a committee early in your career in the health system? Just start talking to people. How did you get there? How did go to things like this, like the career cast, and really just start gathering information. But the laser focus has to be on clinical excellence, because if you start to move into these roles, but people don't respect you clinically, you're like dead in the water. Because I have to look at the same physicians I discipline, they're walking past me while I'm rounding in the ICU to talk about their patients, right? So if they don't respect my clinical judgment with their patients, how are they gonna even take me seriously when I put them on an action plan? Or like, so that clinical being solid clinically has always been really important to me, so that people know when I have to deal with them coming at them from another angle. We all know those people we've seen that we know they can't operate well, or they can't, they don't, and that kind of erodes at your credibility. So I would say for you in the early phases, exploratory, learn as much as you can, ask as many questions, committee here or there, try to sort of get involved, but really focus on the clinical work. And let things come out of your clinical work, like problems that may arise in the clinical arena can drive you to find answers. Like if you don't like the supplies you're using to do trachs and pegs or something, go find out something about supply chain. Why are we using those specific things? How does that work? Like, you know, and that can kind of lead you in different directions, I think.
So I think some people come in, to tell me if I'm wrong here, I think some people come in kind of knowing what they want to do. And there are a lot of folks who are in this exploratory phase during the beginning part of their career. I like teaching. Am I an educator? I'm interested in the finances, but am I really part of the C-suite? And then trying to figure out, but I also feel like some of the times we have that notion that we know what we want. And then you end up finding that's not really what I wanted. And sometimes we also feel I don't know what I want. And then you walk into something and you're like, oh, this actually speaks to me. I feel like I contribute well to this. I feel like I've done something satisfying. How do you teach like learners or reach learners or people you're mentoring when you notice like an aptitude or a skill set in them? And how do you point them in the right direction? How do you help them recognize the skill set themselves?
Yeah, that's a great question because people have certainly done that for me. So I would have to ask them because I'm not sure I do that as well as I should with other people. I think you have to pay attention. Like if you're really going to mentor people and serve in that role and want to, you know, effectively bring other people up and along with you, you have to pay attention. And how do I articulate it well? You know, I think you have to just watch what they have a natural aptitude for and pay attention to it. And then try to ask yourself, what opportunities can I give them that might play to that strength? You know, I'm trying to think of an example so it makes more sense and it's not so abstract. But, you know, I've had residents rotate with me or fellows that rotate with me that it's clear. And Christina Colosimo is an example I'm going to use. Maybe she's on here, maybe she's not. Christina is a great example of a fellow who right away you could see, she was a fellow here, she's now out at University of Arizona. You could see she had a mind for operational type things and system level thinking and, you know, really wanted to do that. And so I would try as hard as I could to find opportunities for her, whether we did a research project together, for example, about trauma finances during the COVID pandemic and what happened there. And I would try to kind of point her in different directions and then help mentor her through those projects. I would have never put her on something like stem cell research and trauma. It was clear that her interest didn't lie there. And I think I think it comes down to paying attention and then helping find opportunities for people to play to those strengths. And it may not be an opportunity you can offer them. It may be like, hey, you might want to talk to, you know, if you're really interested in military civilian partnerships, my partner, John Chavanis, has done this really well, or my partner, Kirby Gross, has done it, and you direct them away from you to someone else. And that's part of the process too, is helping them form connections with people that can play to their strengths. It may not always be you. I don't know if I answered that well. I feel like I just go on.
I thought I saw another hand up.
Oh, this is so fun. Is there another hand?
May have been imagining things.
No. All right.
Well, somebody popped out. Okay, thank you. So what do you think the best career advice you've received has been?
Well, recently, we'll go recently and back. Recently, the best career advice I received was to own your place at the table. I think a lot of us don't always own our place at the table. We always sort of feel like we don't belong, or we feel like we are not the smartest person in the room or whatever. If you're in a role, whatever it is, you have to really own that role and lean into it and legitimize yourself in a role and believe that you can do it. You have to do that. You can't always be doubting yourself and second guessing yourself. So that's the best career advice I received recently, because I've had a lot of trouble with that. You know, I constantly find myself in these roles or these places and I think, well, what am I doing here? And that's a disservice to whoever put you in the role and to yourself, because you're there for a reason. You bring value, you can contribute. So I have to start being better about recognizing I'm wherever I am for a reason, and I have to start contributing. But the best career advice I received early on was to really make an active effort to get to know myself through doing a lot of hard work, like things like the Myers-Briggs Index, like values exercises, like some of the positive intelligence tests, but really trying to figure out who I was and stay true to that. Once I figured that out. And so I did a lot of, I call it like the great excavation, a lot of excavating work about what are my real values? What do I really like to do? What direction do I want to go as my career progresses? And the best advice somebody gave me was to really work hard on doing that. Just as hard as you would work in a resuscitation or studying for the boards or something like that. I had to make that a priority. Are you all stunned into silence, or is there, do we have other questions? There's a hand. No, what is that?
I keep thinking I'm seeing one, but I think it's just the recording thing up there.
Well, let us know. We'll just.
What kind of legacy do you want to leave behind? So you obviously have done an absolutely insane amount of work in a relatively short period of time and have built one of the bylines of the session is building your brand. You've built this brand. What really is sort of the ethos you're trying to leave behind?
Ooh, the ethos. Well, I think the ethos now that I'm trying to leave behind is if I look holistically at, I think I said earlier on that being in the C-suite has enabled me to look at what we do as trauma surgeons through a different lens. And someone alluded to it in one of their questions, like they've fallen at their institution, they've fallen so far behind that it's hard to catch up. I think the legacy I want to leave is that I'm actively helping to kind of bridge this gap and help catch us up to where we need to be as a profession, as a specialty. I want to use the skills and the knowledge I've gained on the other side to benefit acute care surgery, as selfish as that sounds, but I think there's no one I admire more than I admire trauma surgeons. I watch the work our group does every day. I watch the work people do nationally across the country. And I watch the things that we're struggling with, and they are surmountable. All the things we've been talking about today, being paid equitably, defining an FTE and things like that. I really want to help. I hope my legacy is I made some impact on helping generate the discussion, move things forward, and get us back to, get us up to where we need to be as a profession so that we can have, a great path forward with people who want to go into trauma. They love their careers. They want to be doing this for a long time. They're happy. They're not struggling with a lot of the things we're still hearing, being under-resourced, understaffed, underappreciated.
Burnt out,
because we do the best job in the world. You cannot beat this, right? And I want everybody to feel that way. So if I can make like some small difference to get us closer to that goal, I think that's the legacy I would want to leave. We do have a hand. Yes, I'm excited.
So something I think you echoed and Drea echoed, which really spoke to me, was the fact that I think a lot of us are starting out at the back, meaning that we've been sort of doing a lot for so long and never asked for anything. And now we're sort of on the back end trying to ask for support or compensation or sometimes even equipment to do what we do. And the reaction that I think we're seeing, and it sounds like others are seeing, is, well, you've been doing it this way for so long. Why are you asking now? So sort of speaking with your C-suite hat, how would you recommend people start to navigate that and to advocate for themselves and their partners without, I think sometimes I've seen these conversations resort to sort of like threats and antagonistic, and I think that's really toxic for everybody. So looking for ways to build bridges rather than start wars.
Yeah, well, that's a great way to start. One is that you have to go in with the mindset of building bridges and not starting wars, because you're not going to win, right? So if you want to get into, and I think what trauma surgeons did for a long time, because we're used to telling people what to do and people doing exactly that. And it works in the trauma bay because we have a team, we're the leader of the team, and that's how it has to go. It doesn't work that way anywhere else. And you guys know this. It doesn't work at home, right? Nobody cares that mom's a trauma surgeon. And it certainly doesn't work in the C-suite, right? Because they'll just be like, yo, hey, we don't need to listen to that. So I think one is adopting the mindset. It has to be a mindset shift of we're here to be collaborative. We're here to ask for what we want in a very respectful, professional way. So that's step number one. Half the people can't even do that, right? Half of us struggle with that just because it's so ingrained in us to kind of push through. The other thing is to remember what you know from your trauma career. Data is extremely powerful. You have to come to the table with data and at least some sort of well thought out plan. I'll tell you, one of the biggest mistakes I made was early in my career when I decided we should be a pediatric trauma center. And they actually got me a meeting with like the CEO at the time and all these, and I was so excited. And I went in there all impassioned about like pediatric trauma and saving children. And oh my God, we have to do this. And she looked at me and she was like, okay, well, so what's your volume prediction like for the next 5 years with the pediatric trauma center? I'm like, huh? She's like, how much market share are we capturing right now, pediatric trauma? Like, I'm like, what? Blah, 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 blah. And she pulled me aside after the meeting. This woman was amazing. And she said, look, don't ever do that again. She goes, I'm going to give you another chance. You're going to come back to the table with everything I just asked you, but don't ever make that mistake again. If you're going to come and sit at a table with me, you better know exactly what you're asking for and the next 5 questions I'm going to ask. And that was like a formative lesson in just because I felt so strongly. And, you know, you and I would think, of course, everybody wants to save children's lives, which they do. But they also need to know they also hold the checkbook and they need to know that they're spending their money appropriately and making a good investment. And once I went back to the table with everything she asked me and 25 other things, of course, it was like, what do you need? How much money do you need? Go for it. And I saw and she saw that I had the humility to accept the feedback. I didn't start yelling and stamping my feet and getting mad and having a tantrum, because tantrums never work. I also didn't give up coming back to the table. I went back. A lot of trauma surgeons do not like hearing no. It's an ego thing. It's a pride thing. So once somebody tells them no, they're like, I'm never going back to her again. Yeah, I don't like her. I'm never doing that. Well, then you'll never get what you want. So sometimes you have to swallow, you know, the pill and go back. And I was embarrassed. The next time I went back, I like chose my outfit and I was like shaking in the bathroom for a good hour and a half, you know. But then I sat there like an adult and did my whole thing. And here we are 10 years later, you know, with the pediatric trauma center. So, and always under promise and over deliver. So to go along with that example, she asked what the volume increase would be. And I was like, oh, 7%. You know, it ended up being like 52% or whatever. Then you look like a hero because you just kind of undercut it. But under promise and over deliver. Just like we do with our patients. We know how to do this. Trauma surgeons know how to do everything. You always say, I don't know if they're going to make it through the next couple hours. I don't, and you know, a lot of times they probably will, but you don't want to overpromise and underdeliver. You know, you want to underpromise and overdeliver. So we know how to do all this stuff. We're so busy with the work that we're not taking the time we need to push ourselves forward in other areas. And I worry fundamentally that we're going to end up with people who don't want to do this anymore, right? Who just don't want to be in the field. And that's heartbreaking because the patients are never going to stop coming.
That's what I'm hearing come through loud and clear. Yeah. Is it everything you're doing from the boardroom and back is all to serve kind of the ultimate mission of trying to make it a better place. We're going to take care of the kids. Mm-hmm. We're going to take care of the adults. We're going to take care of each other.
Yeah. And the health system. And we're going to keep the health system healthy, right? We're going to keep driving the business and contributing to the bottom line and being good stewards of our resources. So.
Well, speaking of being good stewards of resources, time is an extremely valuable resource. And I appreciate all of you who have spent this past hour with us. I very much appreciate Dr. Fox. I'm lucky to get to work with her on an everyday basis. I'm a little sorry for the rest of you who don't get to. But thank you very much for spending this time with us. You obviously will see us around. And if there's ever anything that I can do to help, and I'm sure Dr. Fox feels similarly.
We better see you in Atlanta. 2026, let's go. See if there's any more questions. I'll have my reading class.
Everybody's just being very kind and thanking you.
Oh, good. Yeah, thank you. Well, thanks for coming on.